Dear colleagues, my name is Horst Sievert from Cardiovascular Center Frankfurt. I was recently asked to give a talk at the Cardiology update in London about the current evidence for left atrial appendage closure as an alternative to anticoagulation. In this first part of that lecture, I will give some background and talk about the early studies about this procedure. And then in the second part, I will talk about two recently published or reported trials about left atrial appendage closure. So the title of this presentation was Percutaneous Closure of the Left Atrial Appendix, an Alternative to Anticoagulation. So these are my disclosures. So atrial fibrillation, as most of you know, is one of the most important causes of death and stroke, and more than 50% of all strokes are due to atrial fibrillation. In the European Union, including the UK, more than 8 million patients are suffering from atrial fibrillation, and more than 7 million are at high risk for stroke and require preventive therapy. Atrial fibrillation causes big clots, and therefore these big clots also cause big strokes, and the mortality of a stroke caused by AFib is 2 times higher than the mortality of strokes caused by other causes. AFib patients are at a very high risk of embolic stroke, and you can use, for example, the CHA₂DS₂-VASc score. And if you look at these data with a CHA₂DS₂-VASc score of 3, your stroke risk within 10 years is about 32%. Anticoagulation is, as you all know, is effective. It causes a 70% stroke risk reduction. So anticoagulation is effective. However, in daily practice, it is often difficult, and it is also difficult even with NOACs. Many patients are just not good candidates for a lifelong anticoagulation. And very often when I give lectures to my referring colleagues, I ask them, how many of your patients in your practice with atrial fibrillation are anticoagulated? And then I usually get the answer 90%, 95%, 99%. And then I say, well, that's very good, because when you look at studies, the percentage of patients who should get anticoagulation and basically get it at the end is pretty low. It's about 50% in all risk groups. Anticoagulation use decreases over time. Most patients stop anticoagulation after a few years for various reasons, and that means in many studies 80% of all patients are not anticoagulated after only 6 years, and this is actually more or less independent from the age. So that means long-term anticoagulation very often just doesn't work. And also when you look at the randomized trials, there's a very high discontinuation rate with NOACs, and these are the randomized trials comparing warfarin with NOACs. You can see that the stopping rate after only about 2 years in all these trials was similar like warfarin, and about 20% within 2 years. This is a typical left atrial appendage clot, and the question to those of you who are doing TEE, how often have you seen a clot outside of the left atrial appendage? And most of you will say that's actually very rare. And we confirmed this in a study in 1,420 patients undergoing TEE-guided cardioversion. And you can see that atrial clot occurred in 6% of the patients. All of them had a clot in the left atrial appendage, and 4 had additional clots in other locations. But 99% of all left heart clots could have been prevented by left atrial appendage closure. LAA closure is a causal therapy instead of a symptomatic therapy, a local therapy instead of a systemic therapy, and something we always want to achieve in medicine. LAA closure is a one-time procedure. It is independent from patient compliance, and there are no late complications. All complications after LAA closure occur within the first 30 days, and it remains effective for a lifetime. This was the first successful LAA closure back in 2001, a 72-year-old patient, AFib since 2 years, multiple contraindications for anticoagulation, very unstable INR. CHA₂DS₂ score was 3, which means an annual stroke rate of almost 6%. Hasbled score was 5, that means an annual bleeding risk of about 9%. We followed this patient for 19 years, no bleeding, no stroke, no TIA. He celebrated his 91st birthday in January 2020 and passed away in April 2020 of a non-cardiovascular cause. Okay, LAA closure does make sense and it is feasible, but where is the evidence? Well, these are just the trials which have been performed with one of the devices, with Watchman devices, more than 6,000 patients, over 15 years of experience. And what is very impressive, all of these studies had been positive. There was no one single negative trial. Okay, you may say LAA closure does make sense and it is feasible and there are studies, but however, where are the randomized studies? Well, we started with the PROTECT-AF trial a long time ago, multicentric, prospective randomized Watchman generation 2 versus Coumadin in randomization 2:1. It was a non-inferior trial. 707 patients had been randomized. And here are the data. LAA closure was non-inferior to anticoagulation with warfarin. And actually you can see that the curves diverted. So the longer the follow-up, the better it is for the device closure. And during follow-up, PROTECT-AF exceeded all expectations. Here you can see after 5 years, there was a significant benefit regarding the primary efficacy endpoint, stroke, systemic embolism, or cardiovascular death. All stroke cause was significantly reduced, as well as cardiovascular death was also significantly reduced. That means if you close an appendage in your AFib patient, you prolong his life. And the reduction of cardiovascular mortality as mentioned. So this is the combined results of two randomized trials, the PROTECT-AF and the PREVAIL trial. LAA closure was as effective as warfarin regarding stroke prevention. There had been slightly more ischemic strokes, but less hemorrhagic stroke, less follow-up bleedings, and overall, again, a significant reduction in cardiovascular mortality. No late complications after LAA closure. However, patients who continue with anticoagulation continue to bleed. Today, LAA closure is much more reliable and safer than in the randomized trials. These are the implant success of different trials, starting with PROTECT-AF on the left side, 90% success rate, and to one of the largest recent trials, the Pinnacle trial, 99% technical success. Major procedural complications within 7 days decreased over time. We started with almost 10% in the early phase of the PROTECT-AF trial, and this is now down to less than 1%. And compared to NOACs, well, we have the Prague 17 trial. 415 patients with high-risk AF had been randomized. 2 devices had been used in this trial, Watchman or Amulet. Primary composite endpoint, stroke or TIA, systemic embolism, clinical significant bleeding, cardiovascular death, or significant periprocedural device-related complication. This was again a non-inferiority trial. We have now 4-year follow-up of this trial. LAA closure remains non-inferior, not superior yet, but you can see that the curves continue to divert because, again, patients who continue with NOAC, obviously they continue to have bleeding complications. We have the Danish trial. It's not a randomized trial, but a very carefully conducted propensity score match study with almost more than 1,000 patients in both groups. Follow-up was only 2 years. And even after 2 years, we had a significant benefit of LAA closure regarding the primary endpoint, which was ischemic stroke, major bleeding, mortality. There was no difference in ischemic stroke because LAA closure cannot be better than anticoagulation in preventing ischemic stroke, but we had less major bleeding. We had all-cause mortality reduced, and also cardiovascular mortality was significantly reduced. Another propensity score match study in patients who had a prior ischemic stroke, and you can see again the benefit of LAA closure with diverting curves over time. Nowadays, LAA closure is in almost all guidelines. These are European guidelines from 24. It's a 2B recommendation in those patients who are contraindicated to long-term anticoagulation therapy. In the US, we have the ACC AHA guidelines from 23, and here it's basically a 2A or 2B recommendation. That means patients can decide whether they want to have their LAA closed instead of having lifelong anticoagulation. Thank you very much for your time and your attention.